Okay, a very good evening, everyone, and thank you all for joining us for this meaningful session today. This is Meet the Specialist, episode 11, and today we are going to be talking about the topic about oncology. It's our utmost gratitude to have invited an honorable speaker with us, Associate Professor Dr. Ho Gwo Fuang, the head of Department of Clinical Oncology, Faculty of Medicine, University of Malaya. So let us introduce him with a round of applause. Professor Ho.
Hello.
Okay, good evening.
Good evening.
So, Prof. Ho, would you like to start about giving us a brief background about the oncology?
Background about oncology, you mean what? Oncology as a specialty or oncology program?
Maybe you'd like to talk more about oncology as a whole, how you carry it out, and what are the branches inside oncology?
So you mean I start my talk?
Yeah.
Okay. All right. I'm going to share my slides. Share screen. Okay, you can see my screen?
Yeah, we can see it.
Okay. So I'm Dr. Ho. I'm going to talk about oncology as a specialty today. So you can interrupt me at any time. In this talk, I just try to introduce to everybody what we do as an oncologist, the kind of patients we meet, and the kind of treatment we offer. And also, I will tell the students, potential students, the oncology training program. A career in oncology. So this is me 25 years ago, 25 or 26 years ago, contemplating a career in oncology. I was a medical student, just like many of you. Still not so sure about life, but I'm quite certain I want to do oncology, actually. That is the purpose I enter medicine. So, yeah. So, fast forward 25 years, that was my planning room, our planning room, last Sunday. So the board is the cases that we have to do. These are the cases on Sunday morning, so nobody was disturbing me. So I get the room to myself. This is a patient with nasopharyngeal carcinoma. I have to treat his tumor in the posterior nasal space. That's our MRI scan that I use to guide us on where to treat. So what kind of cases we see? So this is a young lady who complained of sore tongue for the past few months and swelling. So on inspection, you can see swelling in the lateral aspect of her tongue, and it just looked malignant. So you have to decide what to do with her. Is surgery the best treatment? Is radiotherapy the best treatment? What about chemotherapy? What's the chance of relapse? What is the side effect of treatment? What about alternative medicine? Herbal treatment? Many of them try herbal treatment. So you have to be able to answer all these questions and address their fear and uncertainty. Not just the patient, but also the relatives, and also communicate with their colleagues, because for many conditions we see, the treatment is not offered by single specialty. You have to collaborate with your colleagues in ENT, maxillary facial surgery, or other surgical department to achieve optimal outcome. The dietitian, the dentist, also the speech therapist, as well as the physiotherapist, pharmacist. So you need to collaborate with a lot of people to achieve optimal outcome. And you need to know your stuff. So your surgical colleague will ask you, should I take it out, or you want to give chemo first or radiotherapy first? And if the tumor is more than 4 millimeter in depth, the risk of lymph nodes involvement go up, then you have to advise post-op radiotherapy. So there are lots of consideration, and you need to know how to investigate. Do a CT scan, you see a lot of enlarged lymph nodes in the neck, then the patient has a more advanced tongue cancer and may require more aggressive treatment. So, and you need to be able to read the scan. You cannot just rely on radiologists, because in the end of the day, when you're planning radiotherapy, you have to be able to identify the targets. So, there are lots of, yeah.
Yeah, so Dr. Ho, what are some of the trainings that we have to go through in order to get into oncology?
Yeah, so let me present you the problem list first, and then I'll tell you
All right, sure.
yeah, the steps they have to undertake to train themselves. The problem list is very long, just like real life. So you have to deal with each patient as they come. So this another gentleman, this is a middle-aged gentleman. In fact, he has the nosebleed for quite a while already. He has nasopharyngeal carcinoma, and then the neck swelled up. And then he did not want to seek treatment. He went for alternative medicine, like some of the patients, and the mass get bigger and bigger. In fact, by the time he came to our clinic, he already had metastases in lungs and liver. So it's no longer curable, but still the tumor is disturbing him, is causing pain and bleeding. So you still need to consider some treatment. But the treatment is palliative in nature. So for this case, you probably offer palliative chemotherapy with or without palliative radiation treatment. So for him, we offer a bit of palliative chemo after about 2 months, about 6 to 8 weeks. The tumor is already smaller, in fact, much smaller, responded very well to chemo. We could have cured him if he doesn't have stage 4 disease, but for him to have liver and lung metastases, we can only palliate his symptoms. After the shrinkage of the tumor, you may consider offering a bit of radiation to consolidate the effect so that the mass does not grow back again. So a lot of the treatment we offer may be palliative in nature, but it is still important for the patient. It's not that you have stage 4 cancer, you're going to die tomorrow. There's a lot of suffering, and then to reduce patient suffering and to look after them in this journey is as important as curing those that you can cure, i.e. we don't abandon patients who have advanced disease because they still need people looking after them. A patient with very distended abdomen, so a distended abdomen, then you get to see the surgeon, you get a differential diagnosis, is obstruction, is it tumor, is it constipation, and so on, or is it ascites? So yeah, so it's a very good case for the exam. Then the candidate needs to identify what is the underlying cause, and then you order a scan, a coronal view of a CT scan of the abdomen. So you see the ascites, a lot of ascites. There's contrast in the bowel, so you can see the bowel. The liver is a little bit shrunken. You have a mass in there. So could it be cirrhotic liver with HCC, hepatocellular carcinoma, and ascites? That is one of the differential diagnoses. Could it be colon cancer, liver metastasis? Colon cancer usually does not cause so much ascites, but pancreas cancer or gastric cancer will do that. So could it be cancer of the GI tract causing liver metastasis and cirrhosis and ascites? So lots of differential diagnoses. And then you need to be able to drain the ascites and then institute a treatment plan. So that would be a very typical case for a Part 2 exam in the oncology program. And then don't forget chest abdominal X-ray. This abdominal X-ray show lots of fluids level, dilated loops of bowels, fluid levels, dilated large bowel and small bowel. Obviously, this patient is obstructed. Yeah? So there are other causes of distended abdomen. And a CT scan of the different patient with a lot of, this one looks like metastases, lots of liver metastases, Is then a small bowel. Yeah, this patient is very thin. You can see there's no fat. So this patient is very cachectic. Yeah, so quite sick actually. This is not a very good example of a mammogram, but there's a mammogram lateral view with a huge mass in the breast and some external lymph node, some calcification. So you need to formulate a plan. What we see a lot of locally advanced breast cancer in Malaysia. So you have to know if someone can be cured, someone cannot be cured, what is the best treatment that's suitable for them, and then what kind of breast cancer, because there are many different types of breast cancer as well. And then if the breast cancer is already big, you do a PET scan or CT scan. If you do a PET scan, what is the advantage? PET scan positron emission tomography. So you can pick up something like that. What is that? You probably miss it on the CT scan. It is an internal mammary node. So the devil is in the detail. So breast cancer may seem a bit straightforward. Everybody sees breast cancer, but the management of it require a little bit more care and attention to detail. So attention to detail is very important to be a good oncologist, because otherwise you miss this and you irradiate the breast, so you do breast surgery and irradiate the breast, and you miss out the internal mammary node. So that's why check and double check and check again. That's why when you do a treatment plan, actually it takes a long time to get it right, because it's so easy to make mistake if you don't check and double check and use all the information you have available to you. Okay, to answer Jatin's question, clinical oncology training course. So in the training course, which is a 4-year course in Malaysia, 5 years in UK, you have to know about anatomy. We don't teach anatomy in a class, but you have to learn it as you go along. Molecular biology or cancer biology, you need to know about the molecular makeup of a tumor, and cancer pathology, what is the behavior of a tumor, what kind of tumors there are in each organ. You need to understand medical statistics and pharmacology. If you want to administer poisons or targeted therapy to patients, you need to understand all the pharmacokinetic, pharmacodynamics concept. And then if you want to be a clinical oncologist, because there are medical oncologists who do not give radiotherapy, if you want to be a clinical oncologist who offer radiotherapy and chemotherapy, then you need to understand radiobiology and radiotherapy physics. There is no medical oncology course in Malaysia, so there's only clinical oncology course. Therefore, if you enter a clinical oncology training program, you need to understand radiobiology and radiotherapy physics. In terms of the skill set that you would be trained to possess would be how to offer radiotherapy, systemic therapy. We don't use chemotherapy because chemotherapy is only one type of systemic therapy. You need to be able to manage oncological emergency, how to offer supportive treatment, feeding, treatment for hypercalcemia, obstruction, SPCO, this kind of thing. Palliative care. So palliative care is an important aspect of oncology program, sadly, but that's still the fact that we cannot cure everybody. You need to know how to practice evidence-based medicine, and as important as anything, the attitudes and values are paramount, because you may be a very skillful doctor, but if you have the wrong attitude or wrong values, you may not be a very good doctor. Yes, attitudes and values are very important. So the 3 modules of the program will include the basic sciences, that we talked about just now, therapy and skill, the skill set we talked about just now, and then you need to understand all the different tumor types. Actually, to me, that's what makes oncology very interesting, because if you are interested in brain tumor, you can subspecialize in brain tumor treatment. If you're interested in gynecological malignancy, then you get to do brachytherapy and you treat cervix cancer, ovarian cancer. So that means you can pick and choose. For me, who is a bit greedy, when I want to choose my specialty, if I just choose gastroenterology, I have to deal with colon my whole life. If I choose cardiac surgery, I only do heart. So I want to be able to deal with different conditions. So if you want to have that kind of options later on, then if you do oncology, you can choose to subspecialize, or you can be a general oncologist who do not specialize in anything. Then you get to treat from brain tumor down to the tumor of the big toe, as a figure of speech. Yeah, so you can treat urological cancer, GI cancer, breast cancer, gynecological, lung cancer, and CNS tumor and head and neck tumor. Those to be the major subsites of oncology patients. Okay.
So, Prof, who does the oncology usually work with in the hospital?
Yeah, exactly. That's right. So who do we work with? We work a lot with the surgeons. They are good friends. We have a lot of good surgical friends, but we have more friends than just the surgeons. We have to work closely with the radiologists, because although we need to understand radiology, but we are not kind of expert in radiology, so we have to work with our radiologist colleague, but also our pharmacists, our nurses. We don't work so much with the pure internal medicine people, like endocrinologists or neurologists, but we still need their help sometime as well. So cardiologists help us, neurologists, neurosurgeon, endocrinologists, they help us, and dermatologists. So basically, oncological problems are so multifaceted that basically all the systems may be affected. So we have to basically work with everybody. But our main partner would still be the surgeons, because surgeons are the people who are responsible for curing early cancers. Many early cancers can be cured with surgical excision. If the cancer is more advanced, i.e. in stage 3, then the patient requires combination treatment, surgery followed by radiotherapy or chemotherapy. So you have to work with everybody, really. So you need to be a good communicator. You don't want to upset all your colleagues and nobody wants to work with you. So this is my esteemed colleague, Professor Maniza. That is my esteemed colleague, Professor Ong. Professor Ong is a urologist. Professor Maniza subspecialized in uro-oncology. So they're running a uro-oncology combined clinic in the urological department, you know that, because of the setup. So you see the patient, and this pre-COVID days, the good old days, we don't have to wear masks all the time. So you see the patient and the family, and then decide what to do. The treatment, this is particularly pertinent for prostate cancer treatment, which you have to really decide whether you go for surgery, go for radiotherapy, brachytherapy, or hormonal treatment. There are so many different options. So it's good to see the urologist and the oncologist at the same time. We can get all your questions answered at the same time. So a multidisciplinary approach. So the surgeons are our good friends. They are the most important people who cure early cancers or later stage cancer as well as a combination treatment. So they are very important people. So for those of you who are more surgically inclined, I would encourage you to do that as well. Surgical oncology is a very important specialty. For those of us who are scared of knife, including myself, if I cut the patients, I'm probably going to murder them. So I don't want to be a surgeon because I'm not very good with the knives. So we can still cure some patients using radiotherapy. Radiotherapy cure the second number of cases after surgery. So you can cure cases like nasopharyngeal carcinoma, lung cancer, prostate cancer, esophageal cancer, etc., skin cancer. So you can still cure quite a number of cancers with radiotherapy alone. It's another local regional treatment approach. Yeah, so surgery is a local regional treatment approach. Radiotherapy is another local regional treatment approach, which is very effective for a tumor that is limited to one site or a small area. If a tumor has spread all over the body, then it is difficult to cure with surgery or radiotherapy. but doesn't mean that it is completely useless. For example, lung cancer that has spread to bone is very painful. You can treat the bone and that will relieve the patient's pain. So it is also a very important tool for palliative treatment. In fact, palliative radiotherapy is one of the most effective treatment for bone pain, tumor causing bone pain. So in the module, what aspect will train you to do radiotherapy? To do radiotherapy, you need to know, as we say just now, radiotherapy physics. You need to know how this machine works. It has a microwave inside. Microwave will speed up the electrons from the electron gun. Electron gun will travel along the waveguide and hit the tungsten and generate high energy X-rays, 6 megavoltage X-rays, as opposed to 200 kV electrons. Yeah? So 10 megavoltage X-rays. The high energy X-ray will penetrate deep into the body, that's a must. And then you don't burn the skin. So you need high energy X-rays to treat organs inside. If you use kilovoltage X-rays, you can only treat skin cancer. It cannot penetrate deep inside. So you need to know how this machine works. Therefore, you can use it to your advantage. So you need to know radiotherapy physics. And then you need to know radiobiology. Radiobiology is how X-ray interact with the body. You need to know that. You need to know that the body can only take certain dose of X-ray. After that, you damage the body beyond repair. And how you give X-rays, how much gamma rays or X-rays or electron beam you can give that will get rid of a tumor without causing long-term damage. So that's what you learn with radiobiology. Yeah? So actually, it's a completely new subject. You don't learn it in your course, in your medical course, in your postgrad course, until you do radiobiology. Then you really learn this completely different subject, which really open your eyes when you know about it. Plus radiotherapy physics, which is because after graduation from high school, you don't learn physics anymore, and then after like 10 years, 8 or 10 years, you go back to learn physics from square one again, from learn all the atoms and radiation and radiation decay, nuclear, the isotope decay kind of thing. So yeah, so radiation physics and radiobiology. Of course, you need to understand anatomy. If you don't understand anatomy, you're not going to treat the right place. Yeah? So these are the core skills you require to be a good radiation oncologist. So once you've mastered the skill and the physics of the X-rays, of the different, not just X-rays, but also in the future, proton beam, carbon ion, electrons, this kind of thing, then you can irradiate the tumor, like the patients with the tongue cancer we saw just now. We can treat the nodes without damaging the throat in the middle, or the jawbone, or the spinal cord. So that's high dose area, and you can spare the important structure elsewhere. This patient has nasopharyngeal carcinoma, so he gets high dose to the posterior nasal space. That's the axial view, that's the sagittal view. So you can see the dose in the post-axial space. The spinal cord and brainstem is bare, the mouth is bare. So and that's a coronal view that you can see from the front. So that's actually that was what I was doing last Sunday during this plan. Yeah. So and this one is the job of radiation oncologist, because nasopharyngeal carcinoma is best treated with radiotherapy upfront, not surgery, because it's a very deep structure. Why you need to understand statistics? Because it tells you how much benefit you are going to do for the patient. So patients who have breast cancer, breast conserving surgery, they still have local recurrence up to 30% with breast conserving surgery. With radiotherapy, that drops to 10%. Okay, so radiotherapy reduces the risk of local recurrence and improves survival. Therefore, breast cancer mortality is lower for those patients who had breast conserving surgery followed by radiotherapy. So this is statistics. Some tumors are more sensitive to radiation than others. Sarcoma, for example, renal cell carcinoma are very resistant to radiation. But tumor like T-cell lymphoma, lymphoma of the skin, or lymphoma elsewhere, they are exquisitely sensitive to radiotherapy. This elderly gentleman had this tumor for about 2 months now. It's getting bigger, and then we gave him 20 fractions of radiotherapy over 4 weeks. At the third week, the tumor already almost disappeared. Before the radiotherapy was finished, the tumor has already melted away. So it's very satisfying to treat for those patients whose tumor respond to radiotherapy. And if you want to do surgery, you have to cut a big piece of the skin, for example, but that's unnecessary. Another good example is patients with vocal cord tumor. If you do a big vocal cord tumor, if you do surgery, you have to remove the vocal cord. Patient who lose the vocal cord cannot talk, so you just give radiotherapy. You can cure the vocal cord cancer, and patient gets to keep the vocal cord. So that's where we do the planning in our planning room. So this is one of another day that I was doing planning, and this is Professor Maniza doing planning. She's planning a prostate case. As you see, a good radiation oncologist will have the imaging next to the planning computer, and they are doing the planning, because you need a lot of good image guidance so that you don't treat the wrong place. Okay, so that's our day job of treating patients with radiotherapy. This is a patient with brain tumor in the cerebrum and in the temporal lobe. This is conventional radiotherapy. This radiotherapy is a very low-tech one. It's not a very high-tech technique, just anterior posterior beam to treat a painful hit for bone metastasis. So it's cheaper, easier to do. I think this one is a three-field plan. But the green area is the high-dose area that covers the target. This is a high-end radiotherapy technique. It's called Stereotactic Body Radiotherapy, SBRT. We have this service about 5 years ago now, 4 or 5 years ago. So give very high-dose radiation and get rid of the early lung cancer. So these kind of patients, if they are not fit for surgery, you can still cure the lung cancer by blasting it with high-dose radiation. Maybe 60 grays in 3 fractions, that will be quite reasonable, or 54 grays in 3 fractions, and that will get rid of the tumor without cutting the patient. The other ways of giving radiotherapy, I forgot to put down a slide for brachytherapy, which is we insert a radioactive tube into the cervix to get rid of cervix cancer. But this one, we have to go to theater. This is Professor Kong, our colorectal surgeon. So we are doing a case with recurrent rectal cancer that we put this probe into the tumor bed to improve local control. So for this, we have to turn up. Oncologists have to turn up because we have the radiation license, you see. So surgeons cannot operate this alone, but they do all the work. They take out the tumor, put the probe there. We just have to calculate the dose and then administer the radiation. So this is a close-up of that. That one is mainly used for breast cancer. So early stage breast cancer, elderly patient, nodes not involved. You take out the tumor. The surgeon take out the tumor. We put in a probe and then just irradiate the tumor bed like so. So the this low energy X-ray, 50 kilovoltage. So only treat the tumor bed. It does not damage anything else. So this one, my colleague Professor Anita and Dr. Rosita does this one. It's called Target study. Okay, that concludes our job on radiotherapy, local regional treatment. Any question? I think all clear.
All right, Prof, that was very informative for us. Just want to know, how do you see the field of oncology progress in the future?
Wow, that is a big question. There is a lot of progress in radiotherapy, as we saw a bit just now, which is the development of stereotactic technique and intensity modulated radiotherapy and image guided radiotherapy. In the future, there will be particle radiotherapy using particles like carbon ion or proton therapy, which is quite expensive, so we don't have that machine. So that is the development of the local regional treatment of cancer. I think I better introduce the topic of systemic treatment before we talk about the future development of systemic treatment, yeah? So that you understand
Please
the
go ahead.
concept of systemic treatment. Okay. So systemic treatment means treatment of the whole body. The most famous one, of course, also the notorious one, I'm afraid, is chemotherapy, which is cell poison. So these are cytotoxic drugs. Cyto is cell, toxic means the toxin. So cytotoxic drugs. So it's in black bag. The nurse will administer either through a chemopod or into the granula intravenously into the patient. So that would be chemotherapy. Before you administer cytotoxic drug, our nurse will give education to the family and the patient about the things to watch out for, the side effect, the risk of infection, what to watch out for during chemotherapy. And then we prescribe the medicine, we consult the patient and agree upon a treatment regime. So we prescribe it. Our pharmacy colleague will prepare the medicine inside this cabinet so that they don't breathe in the poison. So that's aseptic unit. And then they give us the chemo, then the nurse will administer it. So that is administration process. So nurses are all gowned up. So that is a poison, chemo given intravenously. Yeah. So this picture was taken many years ago. This one was in an old daycare. We have changed to a new daycare quite a few years already. That's not Selvi. She has retired already. Okay, so in order to be able to administer cytotoxic drugs, you need a bit of knowledge. You need to know a bit about cancer pathology. Different cancer respond to different drugs. You need to understand pharmacology, of course, cancer biology. Cancer biology is also called molecular biology. That one would be the basis of administering targeted therapy or immunotherapy, which we'll talk about more in the future. But you also need to know about it a bit for chemotherapy. And you need to know a bit about medical statistics, because how much survival benefit you are going to get if you give 4 cycles of chemo for someone with stage 2 breast cancer, for example. Then you have to counsel the patient. Stage 2 breast cancer, what is the relapse rate? Let's say 40%, depends on the type of breast cancer. And the chemotherapy will cut down the risk of recurrence by 1/3. So that means you probably get a survival benefit of 8 to 10%. So and the risk of chemotherapy is 1 to 3%, for example, major sepsis. So you have to counsel the patient accordingly, because sometimes the things are not really black and white. It may be a shades of gray. The benefit and risk ratio may not be as clear cut, especially a stage 2 breast cancer. If it is a stage 1, 0.5 cm breast cancer, certainly nobody will offer chemo. If it is a stage 3C breast cancer, survival benefit from chemo is 40, 50%, then everybody will offer chemo. But if it is in between one, like stage 2A breast cancer, ER positive, then what do? Do you offer chemo or not? Then that you get a bit of dilemma. Then you need to know medical statistics. Of course, if you get that dilemma, what you could do is to send off for molecular testing. That's why you need to understand cancer biology to do a test called Oncotype DX. That will give a better prediction of whether this patient will get a relapse or not. If the risk of relapse is high because of the bad genes are expressed, then you can still offer adjuvant chemo. But that one is in kind of more in-depth discussion. What about tamoxifen? It's a hormonal treatment. So for patients who had ER positive, not positive, or 44% not positive breast cancer patients, after 15 years, if they don't have tamoxifen, 46% will have recurred already. So risk of recurrence is very high in these 10,000 women. Yeah. So if you give tamoxifen for 5 years, you cut down the risk of relapse from 46% to 33%. Yeah. So 5 years tamoxifen, risk is not extremely high, you get a survival benefit of 13%. Seems like it's worth it. Yeah? You need to understand statistics, then you understand what is RR 0.61. Yeah, relative risk of 0.61 means risk reduction of 39% of death, of recurrence. The reduction in risk of death is RR 0.70 means risk of death was reduced by 30%. That's a relative risk, and this absolute risk was from 33% to 23%. That means it's about 9.2% reduction of risk of death, about 10% with tamoxifen. So if you understand the statistics, then you can counsel patients accordingly. Then patients understand what are they getting themselves into. Yeah. For advanced breast cancer, for example, if you just give fulvestrant for second-line hormonal treatment for advanced breast cancer ER positive, then that is the survival curve. This curve is called Kaplan-Meier curve, designed by Dr. Kaplan and Dr. Meyer, of course, and it tells you the survival of patients with time. On day 0, survival is 100%, and then some people, percentage of patients who are alive. Yeah, so some patients who die, they will drop off the curve. So if you give them palbociclib with fulvestrant, then more patients will survive longer. Yeah, so that is that's the benefit of this extra targeted therapy called palbociclib for ER-positive breast cancer patients. Yeah, so this is what you understand about the molecular biology of the tumor, the statistics, and the pharmacology of the drugs. So that is an introduction to targeted therapy. We just say a bit more about targeted therapy. The major breakthrough 20 years ago, at the dawn of the new century, Time magazine reported this at their front page. There is a new ammunition in the war against cancer. These are the bullets, and these are the magic bullets. The first one was called Gleevec, which is a treatment for chronic myeloid leukemia. Basically, it cures chronic myeloid leukemia, but it's also used for gastrointestinal stromal tumor. So a lot of patients basically can live long-term with advanced gastrointestinal stromal tumor. So this is targeted therapy. Basically, what it means is that you understand what is the mechanism driving the tumor, and you block that mechanism. Yeah, that's why it's called targeted therapy. So it has less side effect than cytotoxic drugs like chemotherapy. So this is another targeted therapy called trastuzumab. It's a monoclonal antibody against HER2. So if you just give chemo, that is a Kaplan-Meier curve. After chemo, ASC, and paclitaxel, that is survival. After 10 years, survival rate is about 62%. If you give 1 year of Herceptin, trastuzumab is also called Herceptin at that time, then survival rate goes up to 73%. That's an absolute 11.5% increase in cure rate. Yeah? So you cure another 11% of patients on top of surgery and chemotherapy. So yeah, so risk reduction hazard ratio of 0.6. Therefore, that's a risk reduction of relapse by 40%. Okay. This is targeted therapy for lung cancer. The drug is called afatinib. It blocks epidermal growth factor receptor, which is a receptor that drives, when it's mutated, drives the lung cancer to proliferate and grow. So you use this small molecule tablet to block the receptor, therefore you stop the lung cancer from growing. So before treatment, this is CT of the thorax with multiple lung metastases. After 1 month, already much better. Okay, this is another patient with huge lung metastases. Also after 1 month, patient responded very well. So with not a lot of toxicity, rapid and dramatic response in lung lesions to afatinib. Or this one with cetuximab, another anti-EGFR, which is, this combination is not used very frequently. This is another type of lung cancer called ALK mutated lung cancer. That's a targeted therapy invented in a very short span of time, a few years. They got this out, and you give crizotinib, then the lung cleared up after a couple of months. So amazing effect, in better survival than chemotherapy. So you need to understand the tumor biology. If you understand what is driving the tumor, you don't have to give strong poison. We just give a very specific molecule that block off this receptor, then the patient will respond very well with very little side effect. So that is what targeted therapy is about. It's very specific and targeted. Yeah? There are two types of targeted therapy: the NAP and MAP, which is monoclonal antibody, and the NIP, which is a small molecule, designer molecule. Usually, MAP, monoclonal antibody, has a bit less side effect than the small molecule, which still has some side effect like lethargy. So in order to give molecular targeted therapy, you need to understand cancer pathology, of course, molecular biology, which is cancer biology. You need to understand this. Therefore, you can administer the medicine. Of course, you need to understand a bit of pharmacology and medical statistics. There's another type of lung cancer called ROS1 mutated lung cancer. Lung cancer is now subdivided into so many different subtypes that you need to know what kind of lung cancer you're dealing with before you administer the treatment. So crizotinib also works for ROS1. This is a waterfall plot. Good fun understanding different statistical tools. So it shows you the response of each patient. Yeah. So that means majority of patients responded. Some responded very well. Some quite well. Some not so well. A couple of patients progressed on treatment. So overall response rate of 72%. Why? Why 72%? Because you need to respond. The tumor needs to shrink more than 30% for them to qualify as a response. Yeah. If it's shrinkage less than 30%, it's considered stable disease. This is FLORA study. My colleague, Dr. Boon in Kuching, was a co-I for this study, published in New England Journal of Medicine. Osimertinib for EGFR mutated lung cancer. This is so far the third generation EGFR TKI, and it performs better than the first generation EGFR TKI. Tyrosine kinase inhibitor. TKI means tyrosine kinase inhibitor, which is a main type of targeted therapy. Okay, so that is the second major type of systemic treatment. The last but not least is immunotherapy, which is the latest treatment modality available to us. The breakthrough was achieved about 6 years ago in 2015, and the two scientists were given Nobel Prize for their contribution in the discovery of cancer therapy by activating the immune system. So Dr. James Edison, who basically discovered CTLA-4 as a checkpoint for immune response, and Dr. Tasuku Honjo, who discovered program dev ligand, which is another checkpoint to inhibit immune system response. So they got the Nobel Prize in 2018. So that really revolutionized the immunotherapy landscape, because I'm afraid immunotherapy for many years was in the doldrum because years of research failed to produce any good result. So it has never worked until 2015 when they used CTLA-4 inhibitor for melanoma and basically activate the T cells to work on the cancer, to kill the cancer cells. That's the first anti-checkpoint inhibitor, first immunotherapy. Second one is PD-1, which is on the tumor. So you block the PD-1, the one activate the T cells as well. So these are the two main types of immunotherapy available to us. So with that, we need to learn immunology again, which you learn in medical school, and you forgot, and then you have to learn again. Oh, I forgot. So I have to learn again about NK cells, about dendritic cells, about T cells, B cells, all those things. And we have to learn again in the COVID era how it works as well. So it's the same immune system, interferon, gamma, TNF, beta, and all those things. So you have to relearn. This is good fun learning it again. So anyway, after you have learned a bit about how the immune system works and how to manipulate it, then you can give immune checkpoint inhibitor like pembrolizumab, a PD-1 inhibitor for lung cancer. And they discovered a few years ago in Keynote 024 study that just by giving single agent antibody with very little side effect, survival of the patient was better than chemotherapy, which has been a standard of care for years, with a risk reduction of risk of death of 40% reduction in risk of death. This is another study, Keynote 189. So this is pembro chemotherapy plus pembrolizumab. This one is chemotherapy. Also, survival was improved by 20%. Remarkable improvement. You see the gap of the two curves. So wide. Reduction of risk of death by half. So this changed the management of lung cancer completely about 5 years ago. But also, this also works for small cell lung cancer. So you see the survival, 53% versus 30%, 12-year survival. So small cell lung cancer, a very fatal illness, rapidly fatal illness. Now some patients can survive long term. So, but PD-1, PD-L1, and CTLA-4 inhibitor, basically those are main tools we have today. But this research is now very active area of research. There's a chimeric antigen T-cell receptor, CAR T-cell, which is another breakthrough. The person will get a Nobel Prize as well, I think, in the future, because it cured end-stage leukemia. But other cell therapy like tumor-infiltrated lymphocyte, cytokine-induced killer cells, etc., and cancer vaccine. So there are a lot of our colleagues in Cancer Research Malaysia working on peptide vaccine for Prof. Chong, working for peptide vaccine for oral cancer. So yeah, so the digital vaccine. So immunotherapy will be a major player in the future, and we understand a bit more about how to manipulate the immune system. Now, billions of dollars are invested into immunotherapy to develop the next generation of immunotherapy. So this is a waterfall plot of response of melanoma. So a lot of patients responded: lung cancer, head and neck cancer, urothelial cancer, gastric cancer. That's a very good result for gastric cancer. TNBC, triple negative breast cancer, Hodgkin's lymphoma, mesothelioma. We don't see many mesothelioma in Malaysia. So it works across different tumor types because it activates the immune system. So it is not like chemo only work for certain type of cancer. Of course, immunotherapy doesn't work for all cancer type. For example, microsatellite stable colon cancer does not respond to pembrolizumab. So there are certain cancers that are not immunogenic, but some are immunogenic. You should know who to treat. This is a patient of ours in Keynote 394 study. Tumor recurred in the liver. Recurred in the liver, we gave the patient pembrolizumab, responded really well. So this is my first patient in HCC treated with immunotherapy. HCC is a very stubborn tumor. So first time we see HCC, the response to anything really. This is a lung cancer in another study with cemiplimab, huge mass that melted away. So this drug was approved by FDA beginning of this year. You may know Renegeron study, Renegeron, which is a company that generated the antibody that treated Donald Trump last time for his COVID infection. So they also produce checkpoint inhibitor for lung cancer, and it's a very good antibody. As a lung cancer, another patient, huge mass in the study, so responded very well to immunotherapy. So very convincing, with no side effect. Some patients get a bit of skin reaction, skin allergy, but very little side effect. So I captured this slide from the ESMO Immuno Oncology. Now Immuno-Oncology is so important that they have a meeting just on Immuno-Oncology, on immunotherapy, virtual congress. So you can, immunotherapy works with cell therapy, works with pathogen like virus. Also, you can use virus to activate the immune system with proteins, oncolytic peptides, BiTEs, which is bispecific antibody, nucleic acid, and small molecules. That's the targeted therapy we talked about just now. So, and also you need to understand about microbiome, because immune system also interact with the bacteria in the gut, which we now slowly understand. The bacteria in the gut is very important for the immune system, for our neural system, everything. Tumor-infiltrated lymphocyte, CAR T cells. So this is the landscape that is still evolving, is changing every year. So in 5 years, it will be completely different again. Now we are already doing the second generation immunotherapy study with a STING inhibitor. So that means we use a PD-1 inhibitor plus a STING inhibitor with dual immunotherapy and see whether it works better than a single immunotherapy agent. So there are so many interesting and exciting development in oncology, and this is really just the right time to get into oncology because the field is really exploding compared to 20 years ago when I was still a house officer entering oncology. The lung cancer patients, they really suffer a lot because the chemo at that time, like cyclophosphamide, they don't work. Vinblastine for lung cancer, really patients suffer a lot and the outcome is so terrible. And in year 2000, targeted therapy came along. We have the targeted therapy for lung cancer. Now we have immunotherapy after another 15 years. So the field is changing so fast that it's changing more and more, and actually it's getting so exciting. It's a bit bewildering. So in terms of immunotherapy, in terms of development for targeted therapy, we have entered the omics era. So omics era is genomics. So genomics, you need to understand the genetic makeup of the tumor, DNA copy number, mutation screening. So to sequence the tumor, you do next generation sequencing to understand what is driving the tumor, and you understand transcriptomics, like mRNA, the mRNA vaccine you know about, mRNA, so which makes protein. So you need to understand the transcriptomics, so you need to analyze the mRNA, analyze the protein to see what is driving the tumor and what is a microRNA. Now they're talking about microRNA, which is also an important aspect of controlling tumor. But also the metabolomics, what does that mean? The metabolism of the tumor is different from metabolism of normal cells. So glucose metabolism, protein peptide metabolism, and carbohydrate metabolism. Yeah, so glycomics and lipidomics. So there are so many different aspects of targeted therapy, and so many things that you can, if you are more research oriented, you can always have your own lab. I can have a lab if I want. I'm just too busy. I have friends who have a lab. They are clinician scientists, so they do research half of the time in the lab, and the other half of the time they treat patients. We also do research, but we do clinical research. So our research also involves patients. So you can do lab research or clinical research, and that's the exciting thing of being in oncology because there are so many research going on. It's a very humble research of ours using a machine called Remission 360 to heat up patients to fever range hyperthermia. Yeah, these are our MOs. Thanks to them for volunteering. So yeah, hyperthermia, heat up the body and activate the immune system itself. So that is our research.
This is a very interesting case. Prof, can you share with us some of the cases that you experienced in UMMC Hospital while you are working there?
Yeah, so there are happy cases and sad cases. In fact, just now before I came here, I was in the ward, and the patient that I look after for 9 years now, just passed away actually just now about 7:30. So a very dear patient of mine. But in oncology, you slowly have to learn that nothing is forever, everything is transient. So you learn to treasure life and relationship and moments because you know they're only transient. So, for example, in this picture, Chris, Anis, and Yok Yong. So Anis has left us. She's gone to another university to work. It's closer to her home. She's been with us for many years. A very dear friend of ours. So, but they don't stay forever. And also patients, many of them are also our friends because you look after them, they come regularly, you see them regularly, so you form a relationship with them. You care for them and you actually you want them to do well. So it is a relationship. so it is saddening, but we have seen patients coming and going, and it put you into perspective that what life is about is transient process. So it's good for the elevation of your wisdom. I feel I don't want to get too philosophical, but medicine itself, especially oncology, teaches you a lot about life and friendship and and how to treasure it. Okay, so I want to illustrate with a case of a rather advanced lung cancer. If you bring this to MDT, multidisciplinary meeting, your colleagues will tell you this patient cannot have local regional treatment because that's heart, it doesn't count. So that's lymph node, right heart node, right side mediastinal node, left side mediastinal node, SCF node. So I already have N3 disease. So officially, this patient can only be treated with systemic treatment. You cannot treat with local regional treatment. It's not allowed. Oh, there's some dogma in medicine and some dogma in oncology. Anyway, with time, you slowly learn that everything is relative. There is no absolute truth. It's just an approximation of the truth. I'll illustrate to you what that means. But to understand how to treat this patient, you need to master all these skills. You need to know, first of all, the cancer pathology. What kind of cancer is this? Small cell lung cancer, non-small cell lung cancer, adenocarcinoma, or squamous cell carcinoma, any driver mutation, PD-L1 overexpressed or not. So you need to understand all this. Yeah. So you need to understand what stage is this. Yeah? So and what is the recommended treatment plan for this stage of lung cancer. You need to understand medical statistics. You give surgery for this. Everybody do poorly, so don't do surgery. Yeah, to do systemic treatment. Pharmacology. If you give chemotherapy, what's the side effect, everything, you need to understand that. So you need to understand pharmacology. You need to understand molecular biology. If you give targeted therapy, is it going to work? If you give immunotherapy, is going to work? You need to understand that. So you need to have this background knowledge so that you can formulate a plan. Okay, and then you want to consider radiotherapy. Maybe one day I want to consider radiotherapy for this patient. Yes, it's officially not allowed, but nothing is absolute in life. It's all relative. So if you consider radiotherapy, you have to consider anatomy, radiobiology, and radiotherapy physics. So all the skill set you acquire in the MCO or the parallel program, which is now called the FRCR program, that you need to have all these skill sets to decide what to do with the patient. And that goes through your mind the moment you are reviewing the plan, the scans with the patients. So you're really busy. At the same time, you have to communicate and address their fear. So anyway, so this patient has a huge tumor. So after some neoadjuvant chemo, the tumor was smaller. So anyway, I decided to irradiate with a not very high dose radiotherapy for local control. Otherwise, this tumor will cause cough and hemoptysis because it invades the bronchus, the main bronchus. So for local control, if not for anything else, but you can do intensity modulated radiotherapy, IMRT. So then you can bend the beam. Yeah, so you bend the beam so you don't damage the lungs as such. So you can try to don't damage the heart as such. So you don't damage the esophagus. You need to know anatomy well. Otherwise, you will cause a lot of damage. Anyway. So that is a coronal view of the plant. So that's where the tumor was. So formula plant did not give very high dose. I think about 45 grays, 25 fractions or something like that. So anyway, responded really well. And then after that, the PET scan still show a bit of uptake in the lung somewhere. So the surgeon went and take it out. So if we did the tri-modality approach, the center that does it is the Samsung Medical Center in Korea. They use this tri-modality approach and they reported excellent outcome. But it's commercially not a standard treatment plan, but it can be done. So that was the PET scan beforehand. That was a PET scan afterwards. So in order to, so this is kind of extreme case because this case is really difficult. But if you want to achieve good outcome, you really need a lot of skills. You need to master a lot of skills, and you need to have a lot of knowledge about biology, cancer biology, pharmacology, molecular therapy, all these things. Therefore, if you use that all together, then you can achieve good outcome for patient. The patient today is still alive and well. Thus, we treated her 2015 or 20, about 5 years, 4-5 years ago. Yeah, so she's doing very well. Cured, that's good. So she's still okay today, and this long-term control. This is our first patient of immunotherapy. She has a very advanced gastric cancer. She doesn't want, she had surgery. She doesn't want adjuvant chemo, which we told them you need adjuvant chemo. She's very scared of chemo. She doesn't want it. within 3 months, the cancer has recurred. And then she wants chemo. But it's palliative already, it's metastasized. After chemo, she responded well. Within 2 months, the tumor grew back again because it's a palliative chemo, you see. So, and the tumor is aggressive. And then the tumor, this is a sister Mary Joseph nodule. Some of you may know. You've done it in textbook, but you see it in real life as well. So the tumor was growing out of the abdominal wall. At that time, Dr. Wan Zhang, my colleague, had the study, Keynote 061 or 062 study, pembrolizumab for gastric cancer, second-line study. So I was the co-I, so I asked patients to see whether she wants to participate. They're very worried about this new treatment because back in 2015, nobody knows about this. Actually, very few people knew about it. Also, there's some risk of autoimmune conditions and everything. So it is not without risk, so there's a bit of risk involved. After 3 or 4 lengthy consultation, they decided to make the jump, and actually she had the immunotherapy, pembrolizumab, 1 dose. You know what happened after 1 dose? This tumor was bigger. And this is a picture after the tumor progressed. So it's a bit smaller before the immunotherapy. So it's bigger and it's very angry looking and it is bleeding. And what would you do now? Jatin, what would you do if you were me at that time? You have given this new treatment in a trial some more with a lot of possible side effect and risk, and you give to the patient, and then after 1 dose, patient also uncertain, the tumor is bigger. What would you do now?
Not really sure. Maybe I'll seek for my colleague's second opinion because since my strategy already failed.
Okay, you're not oncologist, so it's not fair to ask you that. Okay, so seek for your senior's opinion. That's absolutely the right answer. Totally agree. So if not sure, ask. Yeah, that's the good team member. Okay, so but the team, yes, their boss, right, also don't know the answer. So in the end, nobody knows the answer. So you have to make a decision. So we decided that it's not very accurate to give a judgment after 1 dose. You need to at least try 2 times. See what happens. So we persevere. After the 2nd dose, the tumor was a bit drier, not much smaller, but not bigger anymore. It's about that size, but a bit drier, not as angry looking. And then after we persevere some more, and then the tumor slowly dried up and shrink. So after about 4 to 5 months, so it became like that, completely dried up. You may not appreciate the significance of this event because if I tell you that 2nd-line treatment for gastric cancer, the median survival is around 3 to 4 months. Yeah, so this is many patients will die in a short time. It's a very fatal illness that you appreciate the significance of this moment that the tumor shrinks and then 2nd-line treatment some more, and then in front of your eyes, and then gets smaller and dried up, and then slowly dried up, and then after 1 year, disappeared until today. So I have never seen anything like it before. Second-line treatment for metastatic gastric cancer with single-agent antibody cured is unheard of before that. So that is the power of immunotherapy. For doctors like us, right, we are very rarely impressed. We usually don't get impressed about anything because everything under the sun is the same. So it has happened before, but this has never happened before. It is something that is different from before. It is activating the patient's immune system, and immune system will work the miracle. It's remarkable. So rather than using poison to poison the tumor. So that really changed our entire perspective of what immunotherapy can achieve. After 50 years in the doldrum, immunotherapy was the Cinderella of oncology field for many years until the invention of PD-1 inhibitor, programmed death inhibitor. So that was 2 weeks ago when I saw her, and she and her daughter walked off the clinic. So it's such a precious moment that I just took a picture. Yeah. So yeah, our precious first immunotherapy success case patient. This patient was from quite many years ago now. I was still quite a young oncologist then. I think for about 8 years ago. 10 years is a long time. 10 years ago, I was a young oncologist. Now I'm an old oncologist. In another few years, in 9 years, I will retire. So actually, yeah, working life is actually very short as a specialist. You realize, especially in government hospital. Yeah, you can still retire to private actually if you want. So this patient is a real patient. He came from Somalia, young boy, with a very swollen eye. So can this patient be cured? This so ghastly, this is nasty tumor. So the eyeball is falling out of the orbit. So can he be cured? That the devil is in the detail. There are lots of information you need to acquire. He has no distant metastasis. There's some lymph nodes in the neck, but no lung or liver or bone metastasis. That is the MRI scan, axial view. So that's the right eye in the right place. The left eye was pushed forward by a huge mass in the orbit that also invaded the nasal cavity and the ethmoid bone. In fact, into the right orbit as well. Yeah, does optic nerves really stretch, and that's his eyeball popping out like this. And this is a sagittal view of him. There's a tumor invading some of the dura, invading the basically into the intracranial cavity, and the sphenoid bone at the back into the hard palate, into the nasal cavity. So huge mass. So to treat him, you need a lot of skills. It is not easy. So obviously it's difficult. Surgeon may, yes, a surgical colleague or some surgeon may advocate a very aggressive surgery that cut off everything like this, and then take out the eye, take out the dura. To take out the dura, you have to repair, otherwise the CSF will leak out. Out of the nose, and infection goes in, you get meningitis. So many bad things that can happen. Anyway, so yeah, so very hard to treat him. But there's one good thing about him. This tumor is not a squamous cell carcinoma. That happens mainly in adults. He has a rhabdomyosarcoma, cancer of the muscle, which is sensitive to chemotherapy, partially sensitive. So give chemotherapy and then irradiate it. In fact, he did not have surgery because you have to exenterate the orbit if you do surgery. So yeah, so he had chemotherapy, which downstage the tumor, followed by radiotherapy to the target, to the primary, and the neck. So that was him growing up, a teenager. After a few years, I met him, totally fine and happy. His eyes still there. So it's very satisfying when you can cure somebody. But pediatric oncology is a very special field. So there are pediatric oncologists who help us. So we don't have to do this very often. So the pediatric oncologist who give the chemo, you only need to give the radiotherapy. So for that, I had Somalian patients for many years, which was a bit funny for me. They travel halfway across the world to Malaysia for treatment. Okay.
The breakthroughs in oncology is really impressive, especially the immunotherapy one. Who would have knew the first dose would give like a negative effect, but after a few more doses will actually help even more. The body's immune system is really magical. So, Prof. Ho, before we go on to our next topic about the pathways to specialize in oncology, I believe that we take a lot of technique to break a bad news to the patients as well. So would you like to enlighten us on how you do that, since you probably face this issue a lot when you're working as well?
Okay, let's stop sharing for a minute. Then I can see you, because when I'm sharing, I cannot see you, which is one of the bad thing of sharing. Breaking bad news. Breaking bad news is a very important skill in oncology and palliative care. Because there are a few things you need to take care of. You have to basically give the information. You have to let the patient and the family members know about what is happening. So you cannot lie to them. So you have to tell them the truth. So that means you have to provide information. That's the first thing you have to do. But secondly is, you're breaking bad news. So it's going to make them very anxious or sad or even hopeless if you don't break it correctly. Therefore, you have to take care of their psyche, and that is a difficult balance to strike. How do you tell people truth without damaging their hope? There are a few things I need to observe. One is you need to understand how much they understand first. If they understand a lot, then you don't have to say a lot because they may already be expecting the worst news already. So you have to ask them to tell you how much they understand about the situation. That gives you a clue. Therefore, you're on the same wavelength when you talk to them. Secondly, you probably want to be more specific when you address the question. You need to tell them the problem list. If the scan is in front of you, like the PET scan there, you may want to bring it up. Therefore, when you tell them you have lung metastasis, you can show them the lung metastasis. Therefore, they can understand it better. There's a kind of fear called fear of the unknown. You cannot see the enemy. You are very afraid. And you don't even know what you're afraid of. It's a fear of the unknown. It's very unsettling. So you try to reduce the fear of unknown so they know what they are fearing, what is the problem. So that will show them where is the problem. So that will help. Thirdly, I'm afraid you have to break the bad news. So, so your father has lung cancer, you have lung cancer, and I'm afraid it has spread to the bone and lungs. So you need to give them some time to absorb the information. People will respond differently. There are a few different coping mechanisms that people have. It may be denial, maybe anger, maybe sadness, maybe acceptance. Different people, they are at different level, so their psyche is different. So you need to kind of find out what is their current emotional status. After that, you have to basically respond accordingly. But a bit of moment of silence will help so that the patient the news can sink in a bit. Make sure the patient has somebody to accompany them, not alone, so that they have some emotional support and the environment is protected, not disturbed by phone calls, and so the patient has some room to express the emotion if necessary. Yeah, so the environment, the setting is important as well. The most importantly, after you have broken the bad news, you have to give them a plan. You cannot just leave it there. If you leave it there, it's very bad. And definitely don't give a number. You say you have 3 months to live, you are making a major mistake. Don't do it. Okay, so don't do it. If they press you on, doctor, how long is my life? You don't want to give a very straight answer. It's not that you want to lie, but your straight answer is wrong one because you're not God. So don't play God. So don't tell them that you have 3 months to live because you may be wrong and it's likely that you're wrong. So most importantly, you have to offer them a plan. A plan. What do we do now? Yes, we have a problem. Yes, we acknowledge that. What do you do now? You have to do this A, B, C, D. Okay? And that will relieve the pain. That will relieve your shortness of breath. And that will help with whatever, your sleep and so on. So what is that doing? That is offering something for the patient to hold on to. Okay? So you need to offer hope, a very important thing that you usually don't know about. So hope is important. So do not destroy hope. Yeah, in the most adverse situation, you can still offer hope. I was talking to this patient last night, the patient who just passed away, and husband. Obviously she's terminal. She has terminal breast cancer in liver failure. Bilirubin is 300, but doesn't mean that it's all doom and gloom. You cry everything. You still deal with the issues and you still offer a bit of hope. Is there any hope to offer at end of life? Yes. The hope of relief of suffering. You can relieve the suffering. You address the issue. You acknowledge death is imminent. You acknowledge it honestly. You don't want to lie. But you offer the things that we can do. There are always something you can do. If you cannot do anything, you can offer some comfort by being there. Yeah. So a most important bit of breaking bad news is offering hope at the end, so that the patient leaving your clinic is not completely shattered. Then this consultation is a failure. So a patient should leave your clinic sad, but feeling somewhat assured at the same time that there is something that you can do for them. Does it make sense? It's a very long answer for a short question. But this one actually is an important aspect that people have to learn. Yeah.
I think breaking bad news is a very intricate art that will take a lifetime to learn, and we have to practice it to actually do it properly without hurting the patient's feeling and instilling hope in the patient and the family.
Yes.
So we've got the question covered. Why not, Prof, introduce us what we are all very curious about as medical students. What's the pathway to pursue oncology in our future career?
Yeah, so we're in Malaysia, so we talk about the Malaysian training program. So my last few slides, we talk about the program. I'll share slides again.
Yeah, sure.
Share the screen. Share. Okay, so you can see my screen. Yeah? Oncology training pathways. Thanks to the hard work of my colleagues, Professor Maniza, Dr. Suhu, Professor Anita, and a few of them who have been working very hard. In fact, Professor Anita was the founding person of the MCO program with Professor Fuang. That was me 20 years ago, sitting in my flat in Liverpool. I was doing a medical training at that time, thinking of my career in oncology, because I decided I want to do oncology. In the 2 years of doing senior house officer job, I don't get to do oncology. I did MRCP. So I plan to go to Royal Marsden to further my training. So yeah, so a career in oncology, yeah, which is something that you should consider, even though you're a medical officer or house officer. In Malaysia, there are two pathways to attend the qualification as a specialist in clinical oncology. The first pathway is MCO pathway, Master of Clinical Oncology, a degree through the Ministry of Education. But there will be a new pathway called FRCR pathway, a qualification through the Ministry of Health. Yeah. So MCO pathway has been going on for past 20 years, almost 20 years now. So yeah, MCO is purely conducted locally at University of Malaya, UKM, MC, IKN, HKL. But now we have a few training centers, one in Sabah, KK, one in Penang. Yeah. So in the future, we'll try to have new training centers in JB and Sarawak in the future. Trainees in FRCR pathway need to do at least 2 years in the local hospitals. And if after they have passed Part 1 FRCR exam, they have a chance of further their training in UK centers. There are not many slots available, but Dr. Suhu has really worked very hard to get this opportunity for students to go there to esteem a good center in UK under sponsorship of Bahagian Pengurusan Latihan, MOH, to further training, which is very attractive. But both pathways require minimum training period of 4 years, with the maximum being 7 years. So it is called the National Postgrad Medical Training in Clinical Oncology. Okay. Entry criteria: need to have MBBS, MBCHB, registered with NMC, need to pass MEDEX exam, or have MRCP. Need to have 2 years of post-housemanship training in medical and surgical disciplines. No disciplinary action, and pass the entrance evaluation. Then apply to National Postgrad Curriculum of Clinical Oncology Malaysia, NAPCON. So MCO pathways. MCO pathways, part 1 exam at the end of first year, where you learn all the basic sciences. Part 2 exam at the end of third year, after you've learned all the different tumor sites. And then final exam at the end of fourth year, research project and training progress. FRCR pathway, at the end of first year, sit for FRCR exam, part 1. At the end of third year, sit for FRCR exam, part 2. And then still, that's the end of the FRCR training. After that, in UK, you go for 2 years of senior registrar course. But in Malaysia, you go for the final exam, which is year 4. UK FRCR training is for 5 years. Malaysia is 4 years. So that is the program, basic sciences, tumor site, learn all the therapy and skills, and need to do a research project. Training includes lectures, clinical training, and self-study. And they have to do work, logbook, attachment appraisal, research progress, annual review, and essential courses like GCP courses that they have to attend. And then after they have done the final, there's no exam, just submit your thesis and logbook and everything. And then there's an exit committee review that say, okay, you perform well, no disciplinary issue, research project is done well or published, or the logbooks are all proper, then go for gazettement for, I think, 6 months at one of the MOH hospital. And then you become a full-fledged specialist. And this process has happened many times. Every year we have a few graduates. So they are now heading all the different centers in Malaysia, like HKL, IKN, JD, Sabah, all the different major centers. Sarawak is Sotobun. Sotobun is not MCO graduate. Okay, so just a recap of what we talked about just now. So now the candidate needs to do at least 6 months in medicine and at least 6 months in surgery. So make sure you get that under your belt. So the 2 years compulsory training, post-housemanship compulsory training, needs to include at least 6 months in medicine and at least 6 months in surgery. Then they are considered skillful enough, have achieved minimum level of competency to enter the training program. Okay, and the candidate should not have disciplinary issues. And then these are the areas that the candidate will be assessed. Essential learning activities, seven essential learning activities. How to assess a patient with cancer, how to manage pain, how to manage severe infection, how to diagnose and manage thromboembolic event, management of upper GI bleed, hypercalcemia, and acute hypersensitivity reaction. So actually quite straightforward. So they need to know that enough for them to pass the interview, and it'll be more like OSCE in the future to be recruited into the program. Okay, so that is the entrance requirement. In the program, so the teaching will cover basic sciences, anatomy. Not all of them include formal lectures, though. Some of them will be web tools, and some of them will be learning in the day-to-day activity. Okay, so that's part 1, year 1, and then year 2, continue research project, learn more skills, how to treat all these difficult cases. Year 3, same. Year 4, have to basically submit the workplace-based assessment and research project, and pass the final. Okay, you can get this in the MOH, in the MCO MOH website and the university website. This one is not formally announced where is the submission, but you can approach the basically HOD in the oncology centers to apply. Hopefully, this one will be applied for application for next intake. We have just done our 2022 intake, so it will be the next round, the year after. Those are the information that you can get from the website. Okay, last but not least, life as an oncologist. Work, a lot of it, but work itself is rewarding and fulfilling and give you a sense of purpose. Depends on whether it's a eustress or distress. So some stress may be good for you. Treatment, teaching, research, some community work, or for doctors really, you should do some community work. And a bit of fun, which is good for you to keep up the interest. Write something. Here's my book, just advertising, a very old book from 2015. It made the chart at number 8 back in 2015 or 2016. So yeah, so it's not too bad. So life as an oncologist, cure sometimes, treat often, comfort always. So by Hippocrates. Totally agree. That is life as a doctor in general, but also life as an oncologist. As an oncologist. Sorry. That was my team. This is not my team now, but yeah, so I didn't take a picture of my current team. So teaching X-ray, this is my team. Very good team. In fact, I have many good teams. So they are very good people. So I do hope many of you will join us. We want good people. They will care for the patients in the future. Cancer patients are a very vulnerable group. So they need someone with compassion, kindness. Compassion and kindness, empathy are the important qualities to make a good oncologist. And attention to detail, like what I said just now. Communication skill. You need to communicate and comfort people. If you cannot communicate, how can you comfort people? So communication skill. But I still think kindness is the most important. If you are not kind, you won't be a good doctor, isn't it? So, but attention to detail, all the skills are important.
Yeah, Prof. So what
think
are
that's-
some specific traits that you think that is a must to have in a good oncologist?
Yeah, so the most important traits would be a lot actually. So integrity is important, attention to detail, empathy, communication skill, and an oncologist usually, a radiation oncologist likes to look at computer. If you hate computer, then you won't sit in front of it and draw the volumes, we call it target volumes for hours. You need to have a bit of nerdy tendency to you. But you can still be a medical oncologist. You can learn how to give radiotherapy. You can still be a medical oncologist as well. You can give chemo. Kindness. Kindness is important. And I think lifelong learning. You need to learn continuously. Because if you don't learn, then you are up to date very quickly. You are out of date very quickly. You won't be up to date because things change so fast. So you need to love learning and love to communicate with people. Yeah, and care for people. There's a lot of reward if you care for people genuinely, not for the money. Oncologists are usually not poor one. Okay, so they're usually quite wealthy, especially private oncologists. As my colleagues, as my friends in Pantai or Beacon, they are all loaded with money, very rich people. So it's not about the money, but you get a lot of reward by making people well, improve their quality of life. So they're happy, you're happy. So that's the best way to become happy. You help people, people are better, they're happy, then they are happy, then you're happy. So yeah. So that is the traits. Those are the traits that you need to be a good oncologist. I think that's the last slide I have. Okay, let me stop
Thank
sharing.
you so much, Prof. There was a really comprehensive talk, and I'm really impressed by what you're doing for all the patients in the hospital. Like your dedication at work is really gained a lot of my respect. And due to time constraint, I think that we can only take one question from the chat box. Is that okay with you, Prof?
Oh, chat box. Any
Yeah.
questions?
There's one from Kamango. So she
Yeah.
says, "Good evening, Prof. Ho. May I know what is the difference between medical oncology and clinical oncology? Since you said
Yeah.
in the beginning of the talk, Malaysia only offers clinical oncology."
Yeah. Very good question. That was my question in 2001 when I was thinking of joining oncology, taking up oncology, because in UK, I was in Liverpool at that time. I want to go to London. So I want to do medical oncology actually. So I went to Royal Marsden and I actually applied for medical oncology clinical fellow job. So my friends were in clinical oncology. And then basically they laughed at me a little bit. They say, you come back to Malaysia, you need to be able to give radiotherapy. So the main difference is that medical oncologists don't give radiotherapy. Clinical oncologists give radiotherapy. So that means you have to learn two skills really. You have to learn how to give the medicines and how to give the radiotherapy. Of course, it's more work. In advanced country like in UK, or in US there's radiation oncologists and medical oncologists. The radiation oncologists don't give chemo at all. They don't give any medicine. They just do the radiotherapy. But in the British-based system, like England, Hong Kong, ourselves, India, there are clinical oncologists who are the most greedy ones, really. They give chemo and they give radiotherapy at the same time. So yeah, you can do more things. But there's nothing wrong with medical oncology. You give a lot of drugs. And, yeah.
Yeah, that's really amazing. So there's actually one more question from Dwayne Lai. Prof. Ho, just a quick clarification for the pathways. Are contract officers eligible to apply for the MCO and the FRCR pathways?
This is a very good question. Very hot topic as well.
Yeah,
Um,
especially with the situation now.
I think if you consider the if you consider the criteria, um, it does not say you have to be a full-time doctor in MOH. It does not say that. But the thing is, most of the MCO trainees are sponsored by MOH. So MOH will not sponsor you until today if you are a contract doctor. But there's nothing to stop you from sponsoring yourself. The school fee is not that expensive compared to some of the private medical school. But you have to fulfill the criteria, i.e. you need to be working, you need to fulfill your major requirement, i.e. 2 years of training with acute on-call, with on-calls as well in the medical and surgical field. So if you have fulfilled that, within last 5 years, if you fulfill that 10 years ago also doesn't count. You have to be recent experience. And so probably no reason why you can't apply. I cannot think of it on air at this moment. I think if you don't require the government sponsorship, then you can still apply as a private candidate. And the rules still apply. So yeah, so probably can see why not.
All
If you have any question, you can email me.
right, thank you, Prof, for the clarification. So there's one more question from Julian. Hi, Prof. May I know what draws the line between hope and false hope? Since you said in breaking bad news, you have to give the patient a little of hope.
Very good question. So let's say I met the patient yesterday and say, don't worry, you will get well soon. That's false hope. So that's not telling the truth. So hope means that it's based on truth. The truth may be a bit painful, but just because it is a very bad situation and it's very painful, doesn't mean that you can't have hope. So hope is based on truth. A truth as much as we understand it. None of us understand the whole truth. You understand the truth of the universe? Do you understand the whole truth of the universe? Does dark matter exist? Is there a parallel universe? Do you know the whole truth? I don't think any of us know the whole truth. So you know the truth as much as you understand it. So that is the truth. So hope is based on truth. Otherwise, it's false hope.
All right, thank you, Prof. So this actually marks the end of our session tonight. A special thanks to Prof. Ho for sacrificing your precious Friday night with us despite a hectic schedule. I know you just finished your ward rounds and you're still in the hospital. A really huge thanks to you for your dedication. We have learned a lot from your past experience and knowledge in oncology, and your talk was really, really an eye opener to all of us. You have gained our respect, and oncology is really something interesting and new to me, especially a year 2 student. But after Prof's talk today, it's really an eye-opener to me. And I believe it's now an important field to relieve the suffering of the patients and, as Prof said, give them hope despite suffering from cancer. Yeah, from user to say it's very insightful. Thank you.
Yeah,
And
usually
Prof,
I'm still waiting for you to join MCO.
Prof, we truly appreciate your contribution in oncology, and you really are a dedicated oncologist who have helped people in so many ways. And I really have to go check out your book soon. All right, thank you, Prof. Ho. You may leave the chat now.
Oh,
Thank you so much and have a good night. Go home and
thank
rest
you.
well. Thank you.
Okay, thank you. Goodbye.
Okay, everyone, thank you so much for staying with us till the end. With that, this comes to the end of our talk today. We, the organizing committees, would like to thank every one of you for spending your Friday night with us. And do not forget to like, share, subscribe to MEDSOC's official social media, Facebook, Instagram, and you may also scan the QR code if you are interested to subscribe in our mailing list. Last but not least, fill up this feedback form to give us your valuable feedback for our improvement and for us to plan more interesting talks for you in the future. I hope everyone gained some new knowledge in oncology tonight, and thank you. Good night.